Hi, everyone. In this lecture, we're going to talk about one of my absolute favorite topics because I'm so passionate about it. We're going to talk about sepsis. Our next simulation is going to be about sepsis. So I'm going to get myself situated with my slide deck so that we have something to talk about, and then I'm going to share that with you. I'm never good at sharing and doing this. I just am not. But someday I'll get there. All right. So we're going to talk about sepsis and septic shock, right? So what is sepsis and what is septic shock? Well, that really relates to perfusion and rapid response. So what's happening and why does it matter? So sepsis is a dysregulated response to infection that impairs perfusion. Untreated, it progresses to septic shock with dangerously low blood pressure and failing organs. So, what is happening with sepsis? We've got an infection, it is going throughout the blood, the immune response is chasing it, and it is with an immune response comes fluid, and fluid is following that blood everywhere. So, fluid is leaving the vascular space and it is distributing itself all through the body. So, you should see edema everywhere because fluid is everywhere it's not supposed to be. So, that is what's causing your blood pressure to go low because there's just not enough fluid in the tank to keep those blood pressures, right? And so, do you need blood pressure to perfuse? Yes. And what is perfusion? Perfusion is getting oxygen or oxygen rich blood to the vital organs and circulating throughout your body. So, what are our vital organs? Our vital organs are obviously our brain, our liver, our spleen, our kidneys, our lungs, our heart, all of those things that are right in the core, right? But the blood circulates all the way to the tips of our fingers and to our toes. So that edema is going to go down to the hands, it's going to go down to the feet, but it's not necessarily going to be where these vital organs are. Okay. So we need to get that volume back into the vital organs. A lot of people confuse sepsis with hypovolemic shock. They tend to act the same way. The problem is that when you have hypovolemic shock, right? So you've lost a lot of volume. There's an easy treatment for that, and that's just fluid resuscitation so you can get that volume back in. You have to be careful with sepsis. You have to really maintain a proper balance of that fluid resuscitation because you have the fluid within your body. It didn't go anywhere. You're not bleeding, you're not you have no where for the volume to go. It's still in your body. And once you start to correct things, it will go back into that vascular space. And then if you're not careful, you could have a fluid overload. So it's a really fine line you have to take there. So why does sepsis matter for nursing? Early recognition, again, that rapid response, right? And a fast, organized response saves lives. Truly, sepsis is a big killer of patients. And nursing really is how you can save patients from a sepsis mortality. So the nurse's job is to notice the pattern, right? So you're going to identify those early signs, and then you're going to escalate the early signs and deliver the bundle in the right order. And so, what is the bundle? The sepsis bundle is you're going to do labs and blood cultures. You're going to get a lactate in those labs. You're going to give some fluid resuscitation, that 30 milliliters per kilogram of the patient. You're going to give that the lactated ringers because it's the most like the body's blood of the two that we're going to give. And you're going to give you are going to then trend that lactate, right? And you're going to watch those blood pressures. You want to see if the patient's fluid responsive to that bolus, that 30 mils per kg of fluids. If they're not fluid responsive, we want to initiate pressors, something like norepinephrine very early. We're going to trend our lactates. We're going to get an initial lactate. We're going to see what that looks like. If a lactate is greater than 2, Then we're going to repeat that in 2 hours. If a lactate is higher than 2, then we've got bigger problems than just the lactate. So that's where we're like going into septic shock. Okay. So our concepts to review our assessment. So recognition concepts. We're going to look for those subtle changes in mental status. That is how you can identify sepsis. You'll have some red flags. So your mental status change. If you have depressed mental status, that's automatically sepsis with a low blood pressure and a high heart rate. You can have a lower urinary output, and your lactate is going to be your perfusion marker. You're going to, a high lactate is a sign of organ dysfunction. Start with your ABCs. How is our airway? How is our breathing? What is our circulation? Circulation with sepsis is the problem. So recognize the pattern early and escalate that through a rapid response with an SBAR. So practice that in your simulation. Practice that SBAR, giving the provider those instructions as to what you need. You need them by the bedside, but tell them why. They have 10 patients with 10 nurses that need them at the bedside, but you want to make your patient the number one priority. So make it known. Your interventions are going to be obtaining the cultures before antibiotics. That's so important. We want to know what's causing the sepsis. And if we give it after antibiotics, then that can mess with our sensitivity. And we won't know if we're on the right track. We want to support that perfusion. So again, that 30 milliliters per kilogram. And then monitor hourly intake and output. Once we start perfusing those kidneys will start working again, and then the patient will start peeing. And that's really how we'll know. So you want to make sure that you're doing strict I's and O's on these patients. And then pharmacology, our concept of fluid resuscitation, that 30 mils per kilogram, our timely broad spectrum antibiotics. We don't know what the bug is at the time, but we know we need to get them on board. And then vasopressors titrated to a perfusion target. So generally your target is going to be a MAP of 65. 65 is a good number to titrate where you're not over clamping down. So a vasopressor is going to clamp down on those vessels. And so if you clamp down too much on the vessels, the extremities, then you can stop the perfusion there and you can end up with ischemic limbs. And we don't want to do that either. So we want to make sure that we titrate that appropriately. So how does the concept connect? We start with an infection, and we know that with sepsis, we have a dysregulated response that's going to impair perfusion because it's going to circulate it through the body and it's going to pull the fluid everywhere instead of in that vascular space. Your recognition. So you're going to look for trends and mental status that will reveal early sepsis. You might get a patient that comes in with a fever and a high heart rate and a low blood pressure, but they're mentating fine. That's when you want to really initiate your care. It's when they start to change their mental status that we're in real trouble. So the sequence is going to be cultures first, then antibiotics, and then we support that pressure. And how do we support that? With fluids. And then escalation. A fluid refractory patient needs a vasopressor and a team. So we have that patient, we give them that 30 milliliters per kilogram, and they don't respond. Their blood pressure doesn't go anywhere. That fluid just continued to distribute throughout the body. Then we have a real problem. We need to clamp down on those extremities, constrict those vessels, and we need to get that fluid right back to those vital organs to save this patient's life. So nursing reminders, you want to draw the cultures before the antibiotics, much like our stroke patient where we wanted to do a swallow screen before we give meds. Here we want to give meds, do cultures before meds. We want to trust the trends. So a subtle change is often the first sign of sepsis. So get in there with your patients, do those neuro exams. It's so important to continue to talk to your patient while you take care of them. Don't just look at the monitors. Talk to them. Make sure that the vital signs that you're seeing are supported with the patient's condition. Escalate early. A rapid response is a tool. It's not a last resort. If you call 35 rapid responses and it's needed, no one's going to be mad at you. Make sure you call it. And then vasopressors are high alert medications, so you want to titrate to the ordered perfusion target. All right. You are going to have a great time with this sepsis simulation. I'm very excited to see how you do. Good luck, and I'll see you back here.